We are recording this. Yes. So, and we will post this on our website. So for those of you who want to share it with people who weren't able to join us, that would be lovely. So please, we're gonna do this the best we can. Hopefully this will all work. We know many of you in the far western counties do not have the best access to broadband. And I'm sorry to tell you that I'm in Raleigh, North Carolina, and I have broadband, but everybody in town is using it at the same time. So if something goes crazy, please accept my apologies. So thank you all again for joining us. Care for Carolina is a group of 65 organizations. We are a coalition dedicated to finding an option for closing the health insurance coverage gap. And in that capacity, we are reaching out to people from all across the state in order to find out how the coverage gap is impacting you and also how the COVID-19 pandemic is making that situation more acute than it has been. So for those of you from the foothills to the high country to beyond the Balsam Gap, welcome very, very much. It's my pleasure to welcome the co-hosts for this virtual forum. And we have quite a lineup from all over Western North Carolina. So we have the Western North Carolina Medical Society, MAHEC up in Ashe County, which covers all the West, the AMY Wellness Foundation, the Community Foundation of Western North Carolina, who was amazing in getting so many other partners to be co-sponsors with us. Blue Ridge Health, you'll hear from Dr. Hedspeth in a little bit, the Western North Carolina Bridge Foundation, and Pisgah Health Foundation. So we are absolutely delighted. When we put out the call, folks came to be very supportive of this entire conversation. So also, I'd like to give a brief shout out to Dr. Meg Malloy and Steve Bush, who were the real brain children behind pulling all of these kinds of forums together early on. And many of you have spoken to Meg or Steve, and we cannot thank you enough for doing this. So I also want to thank some of you. I saw names that were familiar. We did in-person live when we were allowed a couple years ago, in-person forums up in Jackson and Macon and McDowell counties. So those of you who are repeat attendees, we really appreciate it. So I'll give you a few brief instructions and then we will get started with the program because I know you're tired of hearing me talk. So all participants right now, with the exception of our speakers, will be on mute so that we don't get a lot of background noise and people coughing and things like that. If you have questions, once we come to the questions, so we'll hold all our questions until the end, go to the bottom of your screen and you will see participants. Click on that and then you'll get a list of all participants. It will also give you a little icon to raise your hand. So when, and I'll repeat this as we get closer. So when you want to raise your hand to ask a question, we'll open up all the mics and people can start talking when it's time for discussion. And Haley will unmute you so you can be heard by other folks. We will ask you to hold your questions to the end and we'll have hopefully a facilitated discussion that will be like we are together in that big auditorium in the community college up in Jackson County, like we were in the past. So without any further ado, unless Erica, you have something you want to add before we get started, we will proceed. All right, so the first speaker is, I'm going to talk about the economic impact on North Carolina of COVID and the coverage gap. And that is one of our favorite people, Jason Gray, who is a senior fellow for research and policy at the North Carolina Rural Center. Jason, take it away.
Thank you, Peg. Good morning, everyone. It's a great pleasure to be with you. So I'm gonna spend about 10 minutes, hopefully no more than 10 minutes, talking about COVID-19 and the health insurance coverage gap, and just what we know, the best of what we know about what is the economic impact from closing the coverage gap and expanding Medicaid. Next slide, please. So I want to put this in two contexts. So up until the pandemic, we spoke of the economic impact of Medicaid expansion and the lack of coverage in a sort of a longer term chronic perspective. And we've got good numbers, good economic analyses around that. But we're far less certain of the pandemic's short and long-term economic impact, what that means for Medicaid expansion. I'm going to share a little bit of what you know, but we're still sort of off the map on that. There is mounting evidence that the pandemic has resulted in diminished revenue for outpatient hospital services and general practices. This is critical for practitioners serving rural and or low wealth rural communities. Next slide, please. Okay, so the numbers I'm going to share with you over the next couple slides comes from an analysis done by the Millikan School of Public Health at George Washington University. It's a team of economists, and they used, they did the initial report 4 or 5 years ago, and it was updated last summer to cover from 2019 to 2022. Next slide, please. So the economic modeling program that this analysis used is something called the Regional Economic Models, Inc., REMI. It is a commonly used, highly respected economic modeling program. And REMI examines the flow of revenue and outputs in local and regional economies. Think economic multiplier. So it's not only just the number of new jobs created, say, from a business expansion, but it's those new jobs, their incomes, then flowing through the local and regional economy, which then is resulting in other people being hired, other people getting paid, and they're spending money. So it's looking at the broader impact of economic analysis. So REMI is used by a number of North Carolina state government offices, DC, the Congressional Budget Office, the White House Office of Economic Advisors, the North Carolina Economic Development Partnership, which is the lead state agency for helping to recruit major businesses into North Carolina, uses REMI. It's a commonly used economic analysis program. So I just wanted to make that really, really clear. Next slide, please. So the analysis, we took the county level data that the report generated, and then we cut it by the rural, suburban, and urban county classifications that the Rural Center commonly uses. So, and then I'll show a little bit at the regional level. So for the 80 rural counties across the state, we're looking at 11,000 jobs by 2022 if Medicaid had been expanded. 279,000 new enrollees, about $1.9 billion of economic impact, and $33.6 million in local tax revenue. So let's just take, for example, let's say that this REMI analysis overstates the economic impact. Okay, so I went in and I just reduced the numbers by 30%. Okay, so for rural counties, that would be that'd be $1.3 billion in economic impact and $23.5 million in local tax revenue. So the point I'm going to make here with this is that even if the numbers aren't perfect, okay, they're significant enough that even if we take a more conservative approach, it's still a big impact, okay? Especially now when our counties are really hurting for revenue. So urban counties, $3.8 million of impact, $45 million in local taxes. That's to be understood given that that's where the clustering of our major medical facilities are. 1.6 million in general impact in our suburban counties and 27.3 million in our 14 suburban counties. So the economic impact is significant, and there are few programs outside of the CARES Act for the pandemic that flushed a lot of money into localities. That there are few policy choices the state could make that would make such a difference in in rural North Carolina. Next slide, please. So I've just selected 5 counties here in Western North Carolina, just sort of fine grain this to see what this looks like at the local level. And I'm going to start with my favorite adopted county of the year, which is Graham County. The analysis for Graham County is that it would create 12 jobs. There is no hospital in Graham County. There's a really fine medical clinic and an urgent care facility. 12 new jobs, 612 enrollees in the program in Medicaid, $2 million in broad economic impact for the county, which for a county with only 8,000 some people is pretty respectable. And then local growth of 44,000 in tax revenue. Compare that to Haywood County, a more populated county, bigger county, 99 jobs, 3,420 new Medicaid enrollees, 20 million in general economic impact, and $527,000 in new tax revenue. So, this varies by county, depending upon the economic structure of the county, whether they have much of a medical footprint. But this translates into real impacts on the localities. Next slide, please. So here we just break out the numbers by the economic development partnership regions. For the combined regions of the Southwest and in the northwestern part of North Carolina, those 2 regions, that's 4,658 jobs. A lot of that is in Buncombe County, and again, in our bigger counties which have higher hospital presences. Next slide. In terms of general economic impact for the 2 Western Economic Development Partnerships, 447,000 million in the Southwest, 372 million in the Northwest, for a combined $846 million of economic impact. Next slide, please. And in new county tax revenue, the estimate is $7.1 million in the Southwest, 5.5 million in the Northwest, for a combined $12.6 million. So again, let's think, okay, that we're being way over eager or overestimating the numbers. We knock that back and it's only $12 million of economic impact in terms of local taxes. That is still a significant factor. Next slide, please. So we're now getting on a little less firm ground in terms of what has the pandemic done to affect these numbers. So the analysis I'm going to use is just looking at, say, from May, we had 478,776 unemployment insurance claims that North Carolina Labor estimated were COVID pandemic related. So how many of those people didn't have health insurance? We don't know for sure. I mean, there's been some national estimates around the Commonwealth Fund, a health foundation estimates that 21% of newly unemployed or without coverage. Using the estimate above, that would be an additional 100,000 people or so in North Carolina. Now, the uninsurance claims have declined a bit since then. So this is just a very general back of the envelope estimate that in addition to the 500,000 we've had statewide that were without health insurance, that would add another 100,000 or so. So 600,000 people without health insurance is 600,000 households and families that are having real issues, both in terms of their health and their economic stability. Next slide, please. Here's what we know about the pandemic impact on health providers, and I will certainly defer to my esteemed medical colleagues to really go deeper on this, to share their own experiences. But the Journal of the American Medical Association in a June article notes that There's been financial impact on 97% of medical practices in one survey. Medical associations in Texas, Indiana, and New York report reductions in work hours and salaries. Fear of exposure to virus or loss of income is a major reason for the decline in visitation. And that pediatric practices in particular are hard hit because they're not in the Medicaid or Medicare stream. Okay? So particularly in rural areas, these practices are relying on Medicare and Medicaid payments. So pediatrics are really hard hit. Next slide, please. Okay, closing points. First, Medicaid expansion, closing the coverage gap, has a substantial benefit that advances economic competitiveness under the best of conditions, okay? And this, so for counties up on the Virginia line, Virginia has expanded. And you are now in direct competition with counties in Virginia who have expanded Medicaid. And we are now at a competitive disadvantage nationally because we haven't done this. In light of the pandemic disaster, closing the coverage gap would support a substantial number of North Carolina citizens who find themselves without coverage. That has huge implications for family economic success, for their being able to save, for their being able to thrive. And finally, while not the sole solution, closing the coverage gap would generate increased revenue to economically devastated healthcare providers. So this is all about supporting the quality of life across Western North Carolina so that our practices can thrive, people will want to live here, and we can grow our local businesses because there is that health ecosystem that's in place and that people are able to access it. With that, I'll hush and I'll look forward to any questions later on. So thank you.
Very good, Jason. Thank you. You know, Jason is a person who can take numbers and make them fascinating and understandable. So Jason, the Rural Center and you are wonderful partners, and we appreciate you being with us today.
You're most welcome.
Our next speaker is from Jason's favorite new adopted county, Graham County. So we are going to ask Becky Garland, the county manager and finance officer from Graham County, to give us a very local perspective of how things are in the very far west.
Okay,
so take it away.
Can you hear me?
Yes, ma'am.
Okay, awesome. So I appreciate the opportunity to tell our story just for a bit about what Medicaid expansion could do under the best of circumstances, and then also address the issue of impacts of the COVID-19 pandemic. So next slide. So I wanted to give you some demographics about our population. We basically, according to recent studies, Graham County has 20.7% of the adult population that's uninsured. On the face of the issue, you may say, well, that's not too badly. That's not too bad, but when you start dissecting the population demographics and start taking out the population that are under 18 who, if they qualify for Medicaid, could have childhood Medicaid, and then the Medicare population, that leaves about 50.9% of our total population that's working age, part of our workforce, who are uninsured. So that's a huge chunk of folks in Graham County that desperately need health care. Next slide. If you look at us against national metrics, and this is coming out of a Kaiser Family Foundation study, you can see on the far left pie chart that in the United States, 72% of families have one or more full-time workers. Well, what does that mean? And what that means for Graham County is that most of our population who are working, or a lot of our population who are working and are falling in that coverage gap, they're your working poor. So it's not like, I say this when I'm talking about the North Carolina Innovations program, this is not a welfare program. This is helping people get the lift that they need who are working every day, who are paying their taxes, who are contributing to the economy, that extra boost in their budget so that they can, number one, access appropriate health care, and number two, make the ends meet. Next slide. So Graham County traditionally has a very high poverty rate. We have 18.9% of our population that lives below the poverty line. How that translates is that the 2018 median household income was a little over $39,000 per year, and family median income was about $48,000 a year. Well, if you look at the marketplace, many of those folks fall in that coverage gap. And just imagine for a moment, as I was pulling this slide together, I was thinking about when I was a young mother, single mom, working full-time, have a child with complex medical issues and a pre-existing condition, had to keep the coverage that we had regardless of the cost. And so there were times that I had to weigh out whether I was going to get groceries that week or pay the health insurance premium. There were many months that our health insurance was over $900 per month. And if you look at a median income of $48,000 a year, if you're trying to make a mortgage payment, homeowner's insurance, car payment, I don't know how they make that budget work. And I'm a budget person. So the bottom line again is that many of our working poor are making too much for traditional Medicaid, but they can't afford their health insurance, and it's not being offered by their employer. So they're just out of luck if it comes to an issue, a major medical issue, and then you add COVID-19. I cannot imagine the stress that some of these families are under, worrying about their family's health in this pandemic, and then what if we get sick? How are we going to cope with the medical bills? Next slide. Just another demographic about employer provided care, which I mentioned briefly, or the lack thereof. Our economic development director, Sophia Paulus, helped me get some data together, and she found that 83.9% of Graham County businesses have 19 or fewer employees. So that means that they're not obligated under the ACA to provide health insurance. And also they're mom and pop businesses. So they're trying to make the same ends meet that these other families are trying to meet. And they're glad and they're happy they can provide a job, but they can't afford to provide a group health insurance policy. Next slide. And then just to look at it in a little different way, Sophia found that 56% of the Graham County workforce members are employed in industries that are not able to provide health insurance, because a lot of it is, again, tourism-based, construction, some retail, but the margins are so slim for our folks that there's no way they can provide the coverage. And then add the COVID shutdown, where Graham County shut down basically our entire economy because we're tourism based before the governor shut the state down to protect our citizens. We have a problem, and it's not going to be solved without Medicaid expansion. Next slide. Looking at our unemployment rates, in January, before we knew the pandemic was headed our way, we had about a 7.5% unemployment rate. We traditionally run higher than the rest of the state because we're construction-based industry, tourism-based industry. So basically at this time of the year, a lot of people are laid off. But look at May 2020, it doubled. And then it's still hovering around 9.3%. So even if you had health insurance, if you lost your job, more than likely you've lost your health insurance benefits as well. Next slide. So what are the economic impacts to Graham County with the COVID-19 situation? Well, again, a loss of jobs translates into a loss of health insurance, but it also, and this goes without saying, translates into a loss of buying power. So spending went down to just necessity items, groceries, gas, and just other needed clothing if the kid woke up and went to bed in pajamas and woke up in shorts. So the spending has gone basically down to necessity. The loss of insurance is scarier to me, and I'm going to explain that here in just a few minutes. But I think we'll see as we're talking through today that many times if you don't have insurance, you're putting off elective procedures and wellness visits, which can have a long-term negative impact on our county's wellness as a whole, which also negatively impacts our workforce. So this pandemic is going to create ripples for years and years and years if people cannot have adequate access to health care regardless of their situation. Next slide. As I alluded to earlier, I took a look at our community health assessment the other day, and I knew this stuff in my head, but I wanted to make sure I was not misspeaking. Just to give you some idea of what happens when people do not have appropriate access to health care, our incidence of cancer in Graham County is lower than the average, but our mortality rate is higher. Well, why is that? Because people put off getting those colonoscopies. They put off going for their annual visits. Women don't get their mammograms. Women don't get their annual. And so by the time the cancer's found, it's usually stage 3 at the very least, or stage 4. Our incidence of diabetes and hypertension and heart disease is higher than our region, North Carolina, and the United States combined. And that trend is growing over time. Again, that's where people are not availing themselves of appropriate wellness, appropriate elective care, and then again, they get into a crisis, and that's, you get into the crisis, you go to the ED. You don't go to the doctor every year to try to manage your health. So this alone, just these findings alone demonstrates the need for accessible and available health care for the residents of Graham County. Next slide. Our economic impacts, I alluded to this, the loss of jobs translates into business closures, translates into loss of buying power, which creates a negative impact on our sales tax base. Between the governor's order and our own state of emergency, as I stated, our economy, we shut it down. Some of those businesses were on the edge, will not reopen. And I've had several folks tell me that. And some of them are still struggling to dig out from the negative impacts on the economy. Our tourism-based economy will continue to suffer, which could create negative impacts to occupancy revenues as well. So our ability, if sales tax is a big piece of our budget, our ability to sustain our budget over time is going to be negatively impacted. We basically cut our budget for Graham County down to the level that it was in 2009 when I first came in as finance officer. And then I took it another 5% for contingency. So that is, we've had to furlough employees. We're creating a negative impact on the workforce as well as the local government. And then as people can't work, then our property tax collections are going to become slower, and our collection rates are going to stay lower, which also creates budgetary constraints, because I cannot budget more as far as my levy is concerned than what my previous year collection rate is. So it put another hurt on the budget. And then for our municipalities who provide water and sewer, they've lost utility revenue. So our abilities as local government to provide the services that we need to provide, especially in the area of public health, public safety, and human services, is being compressed and constrained, and is not allowing us to provide the care that we need to provide for the welfare of the people of the county. Next slide. Just another piece of information is Graham County has a deficit in the number of doctors, not because there's no doctors out there, but it's our remoteness. So again, it's difficult for people to access health care. But the scarier thing to me is we have a good clinic. We have an awesome urgent care. We've done a lot of good things in Graham County to enhance the health care provision for the people. And I think I made this point in January in a press conference. I was worried about our local hospitals before the pandemic being able to survive without Medicaid expansion. This has been magnified humongously. We are 50 miles from the nearest hospital that has a trauma unit and a fully staffed emergency department. One of those hospitals is a component unit of Erlanger out of Chattanooga, Tennessee. Just in June, the Erlanger Murphy campus laid off 11 staff members off their campus, 93 network-wide. So the reason for that is because the inability for them to provide the elective procedures that they needed to provide during the pandemic, and then people being afraid to avail themselves of their medical care by coming in. So the impact of Medicaid expansion on our local hospitals is a huge piece to Graham County because we don't have a hospital. If one of those hospitals closes, our ability to get people where they need within that golden hour is highly, highly compromised. Next slide. So I think Jason's already gone through these demographics, and so I won't repeat those, but more jobs, more spending power, more jobs, more revenue, more Medicaid expansion, more people getting the care that they need without our residents having to spend new tax dollars. Next slide. And that's it.
All right, Becky, you really nailed it. Thank you very much. And I think Graham County is my new favorite adopted county. So thank you. Next, we're going to hear from Dr. Richard Hudspeth. Dr. Hudspeth is the CEO of Blue Ridge Health. And I know, Dr. Hudspeth, you are on a tight timeline this morning because you have a board meeting. So the fact that you're giving us your time, we are amazing. I will turn it over to you, and then you tell us what happens when you're finished, all right?
Great. Thank you. Good morning, or I guess now afternoon, everyone. I've decided to do it the old-fashioned way and no PowerPoint presentation here. I guess the gray hair gives it away, old-fashioned, but nonetheless,
all right, me too.
I appreciate really that overview, and I think the purpose of what I can provide is sort of on the ground, boots on the ground, what this has actually meant to a community health center. As you've mentioned, I'm Richard Hudspeth. I'm the CEO of Blue Ridge Health. I'm also a family physician by training, and just to let you know how I sort of manage my day doing this, I humbly started my day delivering a baby, and now I have the privilege of addressing this important forum. So I have a great joy in the life that I'm doing right now, and I appreciate these opportunities. Because of the diverse audience that we have, I want to first just briefly describe community health centers, the movement, and share a brief history of Blue Ridge. Some of you may be familiar with us and others may not, so I want to make sure that at least that is covered briefly. So there are about 1,400 community health centers nationwide. It is likely the largest single primary care collaborative network in the United States. We serve nearly 10% of the US population. Community health centers have proven time and again their ability to take a public-private partnership, such as a community health center, and accomplish great things. Blue Ridge started back in 1963. I don't know how many know that we've been around for 57 years, and we started first as a migrant health center. We believe we are the oldest existing migrant health center in the United States, and we work hard to live up to this legacy. This vision for Western North Carolina was started by a visionary public health nurse. Her name was Claire Hayden Burson. You know, and our mission, which is to provide quality health care that is accessible and affordable for all, hasn't really changed much over the past 57 years. And you'll see that as I describe sort of our response to COVID and our ability to continue to give care during our insurance gap. We became a community health center in the 80s, and primary care was our basic foundation. Following our mission, which is set by our board, and our board must be patient predominant. So our patients direct the operations of our community health center, and that is required by our community health center charter. We have grown over the years as we have understood what the needs are in communities to try and increase that access. And I'll give you a brief explanation of our growth. So back in the early 90s, we started school-based health centers, and we now have 13 sites in 5 different counties, and we'll be adding a 6th county shortly. We started dental care. So beyond just primary care, we started dental care in 1995 for kids, and a decade later for adults, mostly uninsured adults as well. As you know, dental care for adults is insured, is challenging. We now have 4 dental sites. We started integrated behavioral health in 2006, and just last year we had over 33,000 patient visits for that integrated behavioral health care. We also started affordable pharmacies, to be able to get patients medications regardless of their ability to pay, back in 2009, and we have 3 pharmacies now. We first started in Henderson County, as I've mentioned, and since 2012, we've grown to 8 counties: Transylvania, Rutherford, Buncombe, Polk, Haywood, Jackson, Swain, and our 9th we hope to open soon in Macon County. So as you can see, we work very hard to fulfill our mission. We see ourselves as gap fillers. And so the COVID gap, if you will, and the health insurance gap, that's our job. We work to identify those gaps and solve the problems related to those gaps. And I'll give you some examples related to that. Our first is really, our approach to COVID really hasn't been much different. What are the gaps? We really strive to help the communities in the different communities that we're in to meet the demands that COVID presented to us in those different communities at the time, and that rapidly, as we've seen, changes. Just on another personal note, I spent time in West Africa during the Ebola pandemic, volunteered with the WHO, and I saw firsthand what a pandemic can do to a nation in Sierra Leone. So immediately we met with partners, worked with DHHS and health departments, hospitals, community groups, foundations, really to craft a response and tailor that response over time that meet the needs of the moment related to COVID. So one of the things we did, what you've heard from the other speakers is very true. We saw immediately a 50% reduction in our patient revenue, which we rely on. Patients were told to stay out, stay home. We did that. But it was challenging for us from a financial perspective to do that. Nonetheless, we realized that what we needed were going to be one aspect of the things that we needed to do, not only within the clinic, changing the telehealth and figuring out how to make our patients and staff safe during this epidemic, this pandemic, but also to be able to deploy rapid testing teams, if you will, to serve the community to find out where those needs are. We've done nearly 50 community testing events and continue to do so. We've provided mass testing for long-term care facilities, community drive-through testing throughout our region, other places of business, including places of business for our migrant and seasonal agriculture workers have been very important to keep food on our tables and keep those businesses open. We've been to schools, churches, clubs, boys and girls clubs, a number of different places in order to serve our population. Thus far, Blue Ridge, we've done nearly 10,000 COVID tests just as an organization. We saw a peak of our positivity of those 10,000 tests in July, when we peaked at nearly 14%. We have since dropped them. Of those tests, nearly 40% of those have been on an uninsured patient population. So again, we take our mission to serve the uninsured and underserved as our legacy to move forward. That uninsured burden carries over as we're discussing that insurance care gap, and it hasn't really changed for us throughout the years. So whatever healthcare reform sort of has happened of recent, it hasn't really affected us. We see roughly about 50% of our patients are uninsured in our overall patient population, 50%. We do 168,000 patient visits last year. That gives you an idea of the breadth and depth of really the uninsured problem kind of on the boots of the ground. Since 2013, we've seen a 49% increase to our volume of uninsured patients. But that's what we do. We go out and we find the gaps and we find these uninsured folks that need our help. Prior to the pandemic, clearly, we saw the need to close the coverage gap. And we are dealing with ways to deliver those services even without that change in the coverage gap. But with the devastation of this pandemic, it is really starkly highlighted for us the shortcomings of what an employment-based health insurance system that we have does for us. But as during other times of economic hardship, we have been here as a community health center and other community health centers across the nation and North Carolina to make sure people have access to that care regardless of the circumstances. I want to make sure, though, as we've seen the struggles of other private practices and pediatric practices has been mentioned, we could not do the work that we do without the fantastic partnerships that we've developed through the years here in Western North Carolina. We have great relationships with folks. We're appreciative of those partnerships that I've mentioned before. I know we have a great partnership with MAHEC, and Susan Mims from MAHEC will talk a little bit later. We're also really appreciative of our work as a public-private nonprofit, and we thank our donors and the individuals, as well as the businesses and our foundations in Western North Carolina and elsewhere that support us. We also do get support from local, state, and federal governments that have supported us throughout our history. So it is a challenge for us, but we accept that challenge and we really strive to make sure all people, again, our mission to make sure all people are afforded and have access to our quality health care. And I'll stop there.
Very good. Dr. Hudspeth, we appreciate it. We are running a little bit behind and we know you need to get to a board meeting. If you would like to scoot, we certainly understand. And any questions that come in for you, we will shoot them your way. Does that sound agreeable to you?
That's acceptable.
Very good. Well, thank you very much for making time. I can't believe you were delivering a baby. Now you're on a Zoom call, and now you're going to probably another Zoom call on for your board meeting. So we thank you very, very much.
Oh, you're welcome, and I enjoyed it. And I will definitely look on your website to finish reviewing the conversation that's about to happen. So
excellent. Thank you, sir. Very, very much. All right. So next up, we have one of my favorite people who I only have met once, but he's such a ball of energy that I love him. Steve Bush is the executive director from the McDowell Chamber of Commerce. And he's going to talk to us about a business perspective and how the coverage gap and COVID-19 has really impacted one of our foothill Western counties, and he's connected to the chambers from all over the western part of the state. So Steve, if you would share a few thoughts with us, we'd really appreciate it.
Thank you, Peg, and I hope just welcome everybody. Good afternoon. Thank you for the opportunity to speak today as the Chamber of Commerce perspective. I want to thank all of our partners who allowed us to put this virtual forum together, but most importantly, I'm excited to see most of our friends and families and neighbors from Western North Carolina. Just start real fast by saying how proud I am of Western North Carolina. The Chamber Associations in 26 counties here in Western North Carolina have recently, last year, started a Chamber Health Insurance program for Western North Carolina. Problem is it only helps companies that employ 20 to 100 people. So what about the small businesses? And that's what I'm here to talk about today, is those guys that are out there hurting and that are truly the backbone of our economy. Last year, we were proud to say that the McDowell Chamber Board was signed a letter of support in helping close the insurance gap or work on that project. And we find it important to our healthcare providers, our businesses, and our neighbors and our family members. So this is a very hot topic, personally and professionally for me. We did this before COVID came along, and it was a big issue last year. It's an even bigger issue now. We saw a dramatic increase in unemployment here in Western North Carolina. We're starting to make a bounce back, but we still got a long ways to go. So health insurance is really, really important and critical right now. We have, in my research, I found that there are currently about 870,000 small businesses in North Carolina that employ roughly 1.6 million people. Again, 870,000 small businesses in North Carolina with 1.6 million people employed. That's roughly 45% of the state's workforce. Let that sink in for just a second. 45% of the state's workforce. These are our people that work in the childcare, the restaurants, construction, nursing homes. Some of them working 2 and 3 jobs to make ends meet, and be able to fall into what we call the coverage gap, which means they either earn too much to qualify for Medicaid, but earn too little to qualify for subsidies to afford coverage through the health insurance marketplace. It's just not fair. How do these people survive to run these small businesses? It's unneeded and it's unprecedented in today's society. So the question is, what do? We close the gap. Like I said, as a chamber association, we put together a program, but we need to get down. We're working on one for the smaller guys, but until then, it's up to our leaders in the country or in the states to close this gap for us. I'm also a proud veteran, 22 years United States Army, but what about North Carolina being a powerhouse military state? And these folks that are actively retiring right here in our state, going to work for some of these jobs and doing these types of jobs, unless they have an injury from the military, they got no health care. These are people that have served our country that are coming home to communities that have no opportunity for health care. Even the VA, like I said, they can go to the VA, but they have to have been injured on the military and carry that with them. So how do you justify that to the people that have served this country to come home and fight for health care? It's just ridiculous in my eyes. We're proud of Josh Dobson, Representative Josh Dobson from here in Western North Carolina, and his hard work that he's done for us. But most importantly, I just challenge, and I'm going to be brief on this and just sum it up. It's a business issue for us, and it's important to our community because of the economic impact. Those numbers are found through our partners at the NC Rural Centers. We saw what Graham County put out. I challenge you to focus on the facts, to take a good look at the funding that will come to your communities when our state leaders enact a law that will close the healthcare coverage gap. But most importantly, closing the health insurance gap is the right thing to do. Remember that these are our friends and our neighbors who work and play a vital role in supporting our local economies, and we need to support them just the same. So with that being said, I encourage you to do your homework and talk with your leaders, your community leaders, your state representatives, federal leaders, and we need to close the gap. And Peg, I thank you guys for the opportunity to speak, and challenge you community leaders out there to reach out to your local Chamber of Commerce's and get them active on this, work with their board of directors, and let's get this fixed.
Steve, I want to say amen, brother. That was beautiful, and especially for bringing the veterans' perspective. I think that we have 12,000 veterans in North Carolina who are in the coverage gap, and that is, I think, something that gets forgotten. So I thank you for bringing that and the business perspective.
Yes, ma'am. And again, thank you for the opportunity to speak.
Very good. Very good. Our next speaker is going to be Dr. Susan Mims. She is chair of the Department of Community and Public Health at the MAHEC up west. And so she's going to talk about COVID and the coverage gap from a physician's perspective. So Dr. Mims, I see your slides are ready to go. Please take it away.
Great. Yeah, great. Can you hear me okay?
Yes, ma'am.
Excellent. Thank you so much for asking me to be part of this really exciting forum today. As you said, I am working with the Mountain Area Health Education Center, which is the AHEC site in the western part of the state based out of Asheville, and chair of community and public health. I am trained in internal medicine and pediatrics, and as well as public health. And so the comments about what's happening in the pediatrics world world, I probably bring that perspective as well, and just am the immediate past president of the North Carolina Pediatric Society, so bring that state perspective. And I really focused on what are the challenges to the practices brought on by COVID. And so I will walk through briefly some of those challenges that are especially making this time an opportunistic time to think about doing something differently. You'll see from some of the information I'm going to share that our practices are struggling. And as Dr. Hudspeth said, we are very fortunate to have a wonderful community health system through the FQHC network, and we work very closely with that network, and we are very dependent, especially in our rural areas, to have access to care close to home for patients on a network of private practices. And I see Miriam Schwartz here from the Western Carolina Medical Society, who many different partners who come together to help support this network. And I do think we're very fortunate in Western North Carolina to have great collaborations, which does provide some strength to the situation, but COVID has challenged us. So we can kind of walk through the slides. Oh, I see, I have control, yay, okay. So, one of the challenges is that we, as I think Dr. Hudspeth and others alluded to, we had to redesign the way we provide care very rapidly. Between, the time really of, we've been talking about telehealth for a long time. There had been a number of, challenges on all around to implementing that. But in a very short time, telehealth took off in March, and by May, a MAHEC survey conducted found that 92% of Western North Carolina clinics had made the switch. Other data from the state through North Carolina Medicaid found similar numbers across our entire state, that people were incorporating some sort of telehealth services. Of course, especially I think in Western North Carolina, we have been challenged, as some people said, through broadband cell coverage. We've been on that telehealth call where you start with visual and you get that circle of death right before it says your internet is unstable, and then having to switch to telephone or doing the best we can. Also, the personal protective equipment issues have been a real challenge. So there's a lot of kind of doing the best we can and people coming together, and really appreciate the Western Carolina Medical Society as one of the organizations and others that have helped to source that for our practices. New ways to do infection control, kind of anything on steroids means amplified. We're just trying to, think about a lot of investment for the practices to either separate their clinics, separate waiting rooms, do visits in cars. I know if you are, someone needs care at MAHEC and comes through our big practice for COVID care or any respiratory care, they may well get their full visit in the car, as well as their COVID test. It's kind of a drive-through clinic, which I think gives, people some reassurance. And then, that brings us to testing, and we've really struggled with access to tests or not having that access. And one of the things I think, especially when you think about COVID prevention education, that having that relationship with your primary care doctor is really the best way to build that trust, to get, especially in a time where, COVID prevention messaging has somehow become controversial. And so really to have that trusted relationship is so important. And I think that just underscores why having that care through primary care in the region close to home is so important. As I think Dr. Hudspeth mentioned, we have seen a decline in well care and chronic disease management. During this time, we're starting to see a rebound, but we know that patients, and we worry, I think all physicians and providers are really worrying that patients are not getting what they need. And we know that actually there are, financial consequences as well as health consequences for our patients down the road when they don't get that preventive care. And then, of course, the increase in the behavioral health needs that have just been amplified by social isolation. And so these are all real challenges that I think are impacting us all. I call it COVID fatigue. I think we've all got it really, right? Okay,
Yeah.
so I'm trying to go to our next slide. There we go. And then thinking about, provider well-being, I thought this is really all of us, and probably just some quotes from providers who, and probably true for all our essential workers who are out there on the front lines every day. They've been at work, going home and wondering, am I bringing something home to my family? This Kaiser Family Foundation poll found that, it definitely has increased, the negative mental health effects have increased in more than half of Americans reporting that, more so for frontline workers and those who've lost their jobs. And then the real specific, we talk about provider burnout. I've never been a fan of that term, but we know that was an issue, and especially in rural areas where practitioners find that they are more isolated, and then to have the COVID amplifying that is a real challenge. Fortunately, in Western North Carolina, we have not had the numbers that some other parts of the nation have faced, yet we know that there is a provider caring for every one of those numbers that we see, the numbers of deaths and people who are hospitalized, and even in the outpatient, working through that worry. I think I like this quote, our society's definitely in a collective state of trauma right now. So there we go. Some data to really illustrate what is happening in the practices. The North Carolina Pediatric Society and the North Carolina Academy of Family Physicians surveyed a large number of practices, about over 500 practices, and found that 85% of the primary care physicians reported the patient volume drops of at least 40%, and others even 60 and upwards towards 70, 80% at the beginning. We're starting to see a rebound in those numbers, and we did see an increase in telehealth, as I mentioned, but it did not equate to what was lost from the in-person care. And the rebound is still, significantly shy of where it was. And I think someone mentioned that is especially true in pediatrics. And from a pediatric perspective, we're very concerned about children getting access to their well care and their immunizations, which are so important. Hearing more stories of patients losing their jobs and then losing their access to health care. And some of the steps that these practices reported taking in response to COVID are reducing salaries, furloughing their staff, reducing their hours, which again decreases access. I talked to several physicians who said, I'm not going to take a salary so that I can keep my staff here to see my patients. And I do think that's especially true in our rural areas. And 87% of primary care physicians reported significant or extreme financial distress, and 10% said that they may have to look at closing their doors. Now, since this survey happened, we have had we've conducted the survey twice, and probably will look at it again over time, because we did have practices that had access to the loans, and we have worked hard to get some probably temporary increases in reimbursement for the patients that they care for who are insured. But those things are temporary measures unless we pay attention. And really, every dollar that is coming into these practices helps support them. Another survey that I wanted to share with you that was conducted by MAHEC, and this is specific to Western North Carolina. This was 110 practices in Western North Carolina where medical students actually picked up the phone and called to find out. This was kind of a survey and an intervention all at once. And for those of you who don't know, I didn't really start with MAHEC's role, but MAHEC is an organization that focuses on health professions, education, support, technical assistance, as well as developing the health workforce for Western North Carolina, training medical students and pharmacy students, public health school now, and residents to go out and serve Western North Carolina. And so we found out about the needs, and they were similar to what we've heard, including access to child care for the practices, and the PPE, the education, figuring out telehealth, how to bill for it. And then this included an emergency alert feature to link them directly to some of the work that was available to help support them either through the state or through the Western Carolina Medical Society. But we again heard from practices that they are in a tenuous situation, and especially in the rural areas. So next slide. With that kind of doom and gloom, I did want to paint a silver lining. So some of the good things that we have learned that have come out of COVID is, we are learning innovative ways to deliver care. And I don't think we'll ever go back to the care delivery. I think that doors have been opened that hopefully will not be completely closed, and we'll think about how can we best meet patients' needs in these innovative ways. We have seen a number of organizations, as I've mentioned, who come together to help support the practices, and the network that we have in Western North Carolina. And then the focus, as Dr. Hudspeth talked about, really intentional focus on populations who are disproportionately impacted by COVID and its consequences, and thinking about access to care for those populations. And we do, I think, have an opportunity to ensure everyone gets the care they need. We know that, by a rising vote helps everyone. And we know that people are healthier when they have health insurance. We know that parents who have access to health insurance and care have their children are healthier and get the care that they need. So this is a real opportunity to, and really a call to action to support our practices and that important network, especially in our rural areas. So thank you, and I appreciate being part of this and look forward to the further dialogue.
Thank you, Dr. Mims. You actually got a shout out in the chat box from Adam. Thank you for your leadership. So, and thank you for your time today. And, it's always good to have a pediatrician involved because they will always try to find a silver lining for you. So thank you very, very much. All right. So we are getting close to the end of the talking heads, and then we'll hopefully have some questioning heads come up soon. Erica, you want to take a few minutes and talk about some of the policy outlook for the issue of closing the coverage gap? Sort of tell us where we are and what's on deck for the coming year and how we're preparing. And I will let you take the microphone.
Absolutely. So I'm going to give you a silver lining as well. It won't be as eloquently stated as Dr. Mims, but what I think is, and when we first put this out, we called it the policy outlook, and then someone wrote it wrong, and we realized it was so much better because we're not talking about where we are, we're talking about what we can do to not fix the problems with COVID, but to take us so much further than where we are now to make sure that we can take care of our people. So we have changed that, and we are calling it North Carolina's policy opportunity. Right now, we have the opportunity to expand quality, affordable coverage to nearly 750,000 North Carolinians. We have the opportunity to ensure that all of our frontline workers have access to timely testing and treatment for COVID-19. We have the opportunity to help stabilize the healthcare system by reducing the amount of uncompensated care costs that our providers face. And we have an opportunity to provide a lifeline to struggling families who are already being devastated through the economic disaster that we're facing right now. And we have the opportunity to do this with 90% covered by the federal government. There has been legislation proposed. A few examples of what we've seen: House Bill 655 was a bipartisan piece of legislation. Steve, you mentioned that Representative Dobson was a lead sponsor on that bill, along with Representative Kevin Corbin from out in the farthest west part of our state. And that bill would have brought down 90% federal funding match. It would have been at no cost to taxpayers, and it would have made sure that everyone in North Carolina had an opportunity to get coverage. We've seen House Bill 1040 recently proposed by Representative Sidney Batch out of Wake County. It would expand Medicaid in North Carolina. And we've seen House Bill 1103, access to affordable health coverage for all, proposed by Representative Cecil Brockman, which would provide subsidies to those folks in the gap. What we know is that we need to get to that point of solution. Care for Carolina was created to help North Carolina find a solution to close the coverage gap. North Carolina can close the coverage gap tomorrow. Our legislators can go into session, they can decide to take this up, and they can do something now, and we don't have to wait till 2021. But if they don't, we know that we need them to pick this up day one, that they go back in January, because this is the most important thing that we can do for our state in terms of making sure that all North Carolina residents have access to quality, affordable health care, that they can take care of their families, and that we can combat a public health crisis that is tearing us apart in far too many ways. Now is the time we need them to act.
Thank you, Erica. That was beautiful. And I have heard you talk about this for the last couple of years, and I think coming on the heels of all these wonderful speakers, you really nailed it. So thank you very, very much. Now, I am going to hopefully not mess this up and blow up the computer or the entire eastern part of North Carolina, so you all at least to be safe. So we'd now like to open it up for questions to our presenters. And so I want to make sure that I can see. So as I said, I'll read this to you again, only because I'm afraid I'll get it wrong. So if you would like to ask a question or make a comment, not a speech, but a comment, go to, on the bottom of your screen, you will see where it says participants, of which there are 82. And click on that, and then you will see who all is on the call. So, and then down in the bottom right corner of where you see the whole list of who's on the call, it gives you the ability to raise your hand. So, and I will be continuously scrolling. Erica and Haley will be looking at the same time to see if anybody has raised their hand. I don't see a hand yet, but not to let us waste the time of these good people or lose their expertise. I'll start off with asking a question of Dr. Mims. Dr. Mims, you talked about the COVID impact on the healthcare practices where patients weren't actually coming into the clinics and the offices. But as things have moved forward, where we are getting back to at least some face-to-face or telehealth, have you and your colleagues started seeing more uninsured people in your clinics and offices, perhaps because they were uninsured all along, or they've lost a job, or they're more concerned about their health?
That's a great question. Yeah, as we are seeing people come back, we are definitely hearing stories of people losing their jobs, and concerns about that access to care. And actually, I worry that the stories we are hearing are probably not reflective of the total, picture of what's happening, because it is people who are losing their insurance or have higher bills to pay. We know just all of that, the underinsured as well, that people are worried about seeking care and those costs, especially in this very challenging financial time for everyone. But yes, I actually personally got a call from my brother 2 days ago that he just got laid off, and he works in the food service industry, and he is very concerned. He will not have any health insurance shortly, and so it's very personal too. It's happening everywhere.
Thank you. So I do see a couple of raised hands. The first one I see is Ted Remington. And can you unmute Mr. Remington? Haley.
Okay, can you hear me?
Yes, we can.
Good. Okay, this is for Dr. Mims, and it has to do with a federal government program ongoing for 50 years called USHUS. USHUS is a medical college specifically for members of the uniformed services. As of last week, over 90% of all physicians in one of the 8 military or uniformed services, because it includes public health service, were graduates of USHUS. Can we do that locally? Find these medical students who want to go to college, they have no money, give them a scholarship on the condition that you have to work for us for 10 years. And then you're on your own, but you graduate with no bills, no student loans for medical school. Imagine how that would impact particularly Western North Carolina.
Thank you, Mr. Remington. Dr. Mims, I'm sorry, Dr. Mims.
No worries. Yeah, that's a great point about different options for encouraging people to go into practice and rural practice. And I think that MAHEC really has a whole program to focus on developing rural practitioners through the Rural Health and Initiatives program. And that's a great example you cite from the armed services. And so definitely the amount of debt that is incurred when in the training is one barrier to service in rural areas. Dr. Hudspeth talked about the FQHC system, where and our rural health centers do offer health services loan repayment to help recruit people to the rural areas. And we know that there are additional barriers to continuing to maintain service in those rural areas. And in part, an idea like that to get people interested and trained, and we've got lots of programs, and then thinking about, okay, how did they sustain those practices? And one of the challenging things about Western North Carolina is our disproportionate payer mix toward public payer, in part because we are a retirement area. We have a higher percentage of patients who are insured through Medicare. And oftentimes practices can help offset some care for the uninsured with more insured patients through private commercial insurance. But our practices aren't able to do that as much in Western North Carolina because of the way that our payer mix is. So it's one thing to train and get interest, and then you get this, energetic, enthusiastic providers that want to go out and serve the rural areas. And then they have to be in a practice that can sustain itself so that they can, have their staff and serve those patients. So I think it's that whole spectrum, but you bring up an excellent point on the training aspect.
Thank you, Dr. Mims. I see a hand from Philip Belcher from the Western Foundation. Haley, can you unmute Mr. Belcher, please? All right, Philip?
Thank you. Thank you. My question is really probably to someone from Care for Carolina, maybe Erica. The coverage gap has certainly been exacerbated by the pandemic, but as several speakers have mentioned, it certainly existed for a long time before the pandemic. And the information about how it affects the economy, how it affects rural hospitals, it's important. It's not brand new. Again, it's being exacerbated now. So my question is, what are in a day when states like Missouri are expanding Medicaid, what is the argument against doing it when 90% of it is paid by the federal government? So I'm trying to figure out if the objection is based on economics, or is it mostly ideological when it comes to your interactions with the legislature and trying to move this ball a little bit? Thank you.
Absolutely. And Philip, thank you for that question. So we hear a couple of different arguments, and there are two that sort of consistently come up. So I'd love to take an opportunity to address those right now. The first argument that we hear come up, you alluded to, which is the cost. So there is sort of a rumor of sorts that has been pushed around that the federal government could withdraw the 90% funding match at any point in time. It's been likened to other programs where the federal match has shifted up and down. There's a difference between this program and other programs where the match has been shifted up and down, and that's that the actual amount that the federal government proportionally provides is set in stone in legislation. In the Affordable Care Act, it states that the federal government will cover 90% of the cost of any form of Medicaid expansion in perpetuity. Congress would have to go in, pass legislation, have it signed by the president. We've seen how these things go, in order for that 90% to change. That is not something they can go in one day and say, we're just going to shift this. It would have to be a complete change in the Affordable Care Act legislation to see that done. So that is not a true concern. That is not something that we are going to see happen. That's number one. Number two, that we do hear the ideological piece, and I'll tell you what I hear that I think is probably a bit offensive to many of the folks who are on here who practice and work with these people, that we hear, not wanting to cover people who aren't taking care of themselves. And what's missed there is that over 63% of the folks living in the gap are working. These are people who go out every day and maybe they make minimum wage, or maybe they work multiple jobs, but they can't get to that above that poverty level to make it. One example I love to share, if you're looking at a single mom who has a child, if she makes more than 42% of the federal poverty line, she cannot qualify for Medicaid. That's around $7,200 for a family of two. She's working and making minimum wage full time, she's making double that, but she's not making anywhere near enough to get a subsidy in the marketplace. So the people who are stuck right now, they're not the people who aren't working. They're the people who are and who can't get the help that they need. They can't qualify. They don't make enough money to get help. So, those are the two arguments that we hear the most when we talk to legislators who have not been supportive of this. And again, these are not arguments that hold water.
Thank you, Erica. Philip, did you have any follow-up? Very good. Very good. I don't see another hand raised. Yeah.
I just want to jump on that too, because I want to go back to the economic. We're not talking about excuse my bluntness here, people. We're not talking about freeloaders out here just giving money out to nobody that's doing anything. We're talking about working people that are in need right now and closing this gap. As Erica well stated, we're talking about the people that make too much for Medicaid and too little or too little to qualify for the subsidy. So programs are out there, they're just stuck in this gap. And to have a gap anyway it's nonsense. And that's what we're talking about. We're talking about people that are working hard, and most of our small businesses that are the ones that are struggling and hit the most. The single moms, or even the young couple that's starting, that maybe has that career starting out in the restaurant that maybe eventually will work forward. But that's the people that are hurting the most that we're talking about impacting the most. And so I just wanted to put that back out there about that gap. We're not talking about just handing out money freely to somebody who's not working. This is about the working people for the most part. When I address it as a Chamber of Commerce, this is what we're looking at, is those people that need us the most. So thank you, Peg. I'm sorry.
Oh, no, I'm glad. Actually, do any of the other panelists have comments on Erica's remarks?
If I could just jump in and just to follow up on Steve. So, you know, the Rural Center is doing a lot of work now around entrepreneurship, small business development.
Yes, sir.
Over the past 15, 20 years, really, nationally, we've seen a drop off in small business formation. And there's a bunch of reasons for this. It's, you know, the giant corporations taking market share, but there's been a drop off. And the Rural Center recognizes that the dynamism of rural economies comes from creating new homegrown jobs. Okay, so and for people of more limited economic means who want to start businesses and who are too often financing their business development using credit cards because they can't get financing elsewhere, closing this gap provides a benefit, a financial security benefit that allows them to get that business started and get going. So it's for all those people who are working already and they're in low wage jobs and they're not able to collect the assets. We have counties in Eastern North Carolina where 40% of the population is making below 150% of the poverty line. Okay. We got a lot of people below poverty, but we've got a lot of people in that gap between 100 and 150%. And the Medicaid expansion would, I think, cover up to 138%. So we've got a gap of people who are working, but they're not making enough income. They're not be able to create savings in order for them to accelerate their lives. So this is part of that support system that has to be there to do that. So, and I thank Steve for the work he's doing out in McDowell that really brings us home.
Very good. We are coming to the end of our time. I see one question from Dr. Meg Malloy. Meg, if you can do it in 1 minute, I will give you the microphone.
I think I'm on live. Can you hear me?
Yes, ma'am.
So I'm just going to follow up on what Steve just said and a question that Miriam Schwartz also asked, like, so how can we talk to our legislators? And I'm just saying that because I've had the opportunity to speak to many business leaders, chambers, and community leaders this year. And that's the question that we've been discussing. If there's an opportunity for you all to think about doing what Steve has done and what Becky has done and have your board discuss this and bring some of this information back, maybe review this webinar and think about looking at a fact sheet that Care for Carolina can provide on how many jobs and how much revenue will come to your county. Jason has referenced that, but we have data for every county, and focus on the issue. I think that some of that political uncomfortable discussion that that Philip asked about can go away. I think it's just important that we just share our facts and focus on the issue, take it to our boards and consider discussing this and passing a resolution to support closing the gap and adding your voice to this conversation and letting your legislators know. That's the only way that we can continue to advance this discussion, by focusing on information and refuting questions that once sometimes people look at the questions and they realize that they've been hearing something that actually isn't true. So I think it's really important that we continue this discussion, bring it to your board, and if you have any interest in making a resolution, your county commissioner, your town council, your chamber, or signing support, that's part of what my role is with Care for Carolina and NC Child. I'd be very happy to follow up with you after today.
Very good. Thank you, Meg. So Haley, I'll ask you to bring up our last slide. And I will close with thanking you all for your time. To our panelists, you were very, very compelling. And my heart is full listening to all that you've said. So, and I know that to give us your time, you are committed to closing the coverage gap. We will be in touch, as Meg said, with your own personal county fact sheet. Here's an example from Avery County. This will tell you, and it's all supported because we never do anything in public health that's not got a million footnotes on it, where the numbers come from. This will tell you the impact that closing the coverage gap can have on your county. So we will send that to each of you, and so you will have what you need to start the conversation. And we will also send some information about follow-up and action steps that you might be willing to take, or you might think about taking. As Meg and Steve said, you know, now the burden is on all of us to let our policymakers know what's going on and what we feel and what we believe will help North Carolina. So that, be looking for that tomorrow from Erica. If you represent a town or county government or a local chamber of commerce, as Meg said, Erica and Meg can help you tailor resolutions from your organizations in order to move this issue along. When the members of our General Assembly hear from us and hear from you, they will know that you are, that this is not an issue that's going to go away. So again, there are people, 600, 750,000 that need our help. So we thank you for your time. Again, panelists, thank you. I see lots of stuff coming up in the chat box. Erica, is there any last word we should say? I'll give it to you. We've got 1 minute.
The only thing that I will say is that we need your help. We need your help to get this done. So please be on the lookout tomorrow for that email. And Dr. Meg Malloy is incredible working with counties and businesses, and she is excited to work with you as well. So please just be on the lookout, and hope to talk with all of you soon.
Very good. Unless anybody's got any last comments, any panelists? If not, we are at 1 o'clock. And I think we are adjourned. Thank you all. Bye.